Hello, everyone, and welcome to today's edition of Pathcast. Today is April 7th, 2026. I'm Rifat Manan in California. And today we are very delighted to host Dr. Andres Acosta, who is a renowned genitourinary pathologist, and he currently serves as Associate Professor of Pathology at Indiana University. And he is going to deliver a very comprehensive talk today covering different aspects of GU pathology, which would be particularly helpful for trainees who are preparing for their boards. And in today's lecture, he will focus on renal tumors and testicular tumors. And hopefully we plan to have a second lecture later where he would be talking on prostate and bladder pathology. We are very lucky to have Dr. Acosta to share his knowledge and expertise with the trainees especially. And at the same time, I would also like to acknowledge all the residents at Indiana University Department of Pathology and the fellows who have joined this session live. And thanks to all of you for participating in this session. And you can also have questions for Dr. Acosta at the end of the session. You can feel free to ask or type your questions in the chat box and we will pass on to Dr. Acosta. So thank you, Dr. Acosta, for joining us today. Over to you. Oh, you are muted. 1 second.
Can you hear me now?
Yeah, you're good.
Yeah.
Thanks.
Good morning or good afternoon, depending on where you are, everyone. And Rifat, thank you so much for inviting me to be part of this session. It's my pleasure to be here. So in this session, we are going to talk about renal tumors and testicular tumors and a specific group of testicular tumors. I will try to keep the content board relevant, but some of the things we're going to discuss may not be in the boards, but are important for your daily practice. So at the end, we can certainly go over some questions. And if you have any specific concerns, if you have been studying for boards, I'm happy to go over that. So in the first part of this talk, we will talk about renal tumors. And the way I envisioned this talk was to focus on the 3 types of renal tumors that will represent 90% of what you see in any pathology practice, which are clear cell renal cell carcinoma, papillary renal cell carcinoma, and oncocytoma. And we will see the rare renal tumors as differential diagnosis for this common renal tumor types rather than focusing on them. And in the second part, we will talk about testicular pathology and in particular of germ cell tumors of post-pubertal patients, which are the ones that we see more commonly in practice. And also the pre-pubertal ones are probably going to be covered by pediatric pathologists. So let's start with the most common renal cell carcinoma type, which is clear cell renal cell carcinoma. And before I start talking about renal tumors in general, the trainees that work with me know that I think it's very important to consider 3 basic things when you look at a renal cell tumor specimen. The first one you can tell on gross examination or at very low magnification, and that's whether the tumor is solid, cystic, or solid and cystic. The second thing you can typically tell at intermediate magnification, and it has to do with the architecture of the tumor, whether it's, solid with nests, papillary, tubular papillary, or entirely cystic or entirely tubular. And the third thing you can usually tell at intermediate to high magnification, and it has to do with the cytomorphologic features. Is it composed of eosinophilic cells, of oncocytic cells, of clear cells, and what are the nuclear features of the tumor? So let's start with clear cell renal cell carcinoma. This is the most common renal tumor type. It's about 70 to 80% of renal tumors on nephrectomy specimens. And it can be sporadic or associated with syndromes. The most common syndromic association for this tumor type is von Hippel-Lindau. And there's a much more rare syndrome, but can be associated with renal cell carcinomas with clear cell features, which is the BAP1 syndrome. These patients also tend to develop uveal melanomas and also mesotheliomas as part of the syndrome. The characteristic finding in cytogenetics, and this is a classic finding that you will find and you will see in all the books, is that there is loss of the short arm of chromosome 3p, and this is one of the hits that the VHL gene gets when it's inactivated, because VHL is the main driver of this tumor type. Inactivation of VHL basically leads to activation of the HIF pathway and of activation of hypoxia-induced genes. And loss of BAP1 is associated in these tumors with transition to high grade and typically with aggressive clinical behavior. So differential diagnosis of clear cell RCC, in my opinion, includes mainly these 4 tumor types, but others as well, especially because there are variants of clear cell renal cell carcinoma. But the ones that you have to keep in mind are clear cell papillary renal cell tumor. We don't call it carcinoma anymore. TFE3 fusion renal cell carcinoma. This is a rare tumor, but it's important because it's very aggressive and you don't want to miss it. What we call now Yolk RCC. This is a rare tumor type. And then tumors within the spectrum of renal cell carcinoma with fibromyxomatous trauma, which are driven by mostly TSC1, TSC2 mutations and behave more indolently than clear cell RCC. So grossly, as you probably all know, clear cell RCCs tend to have this sort of like yellow or golden yellow color when you cut through them, and their cut surface can be variegated because they tend to have necrosis and hemorrhage. So those findings are quite common. Here you can see that this tumor in particular is extending probably into the renal vein here in the hilum. I don't know if you can see my pointer here, right? Sorry, let me pull up the pointer so that you can see that. Okay. So microscopically, clear cell carcinoma is composed of clear cells that are typically arranged in nests, and these nests are surrounded by this delicate branching vasculature that has been described as chicken wire vasculature in the literature. At higher magnification, you can appreciate that, again, the cells have clear cytoplasm. The vasculature is very prominent. You can have areas of partial regression with fibrin deposition within the tumor. This is quite common. And again, note the prominent vascularity. So due to this prominent vascularity, these tumors can have internal areas of hemorrhage, which are a quite common finding in clinical practice. And also keep in mind that sometimes these tumors can show spontaneous regression, as well as regression induced by some of the neoadjuvant treatments that we are now using. And in this case, you can have complete erasure of the tumor cells, but you will still see this delicate branching or chicken wire-like vasculature that you can see in these pictures here. Another finding that is quite common in these tumors is what we call a bloody gland appearance. This is because blood will accumulate within some of the nests, creating these bloody gland-like structures that you can see in these 2 pictures. And in this picture, what I'm trying to show is that clear cell RCC, of course, can show areas with more eosinophilic cytomorphology, and this in clear cell RCC tends to be associated with transition to higher grade. In these 2 micrographs, again, you can see clear cell RCCs that have a very characteristic appearance here on the lower left, and then transitioning to higher grade areas on the upper right, that at higher magnification, you can see have higher nuclear features. And again, here the cells lose their clear cytoplasm, they become more eosinophilic. And This can happen in other renal tumors as well, but it's slightly more common in clear cell than others, or I would say more than slightly more common in clear cell than other tumor types is the presence of rhabdoid change or rhabdoid cells. So the presence of rhabdoid components makes these tumors grade 4. And rhabdoid cells, like rhabdoid cells in other tumors, are characterized by eccentric nuclei and an eosinophilic cytoplasm located on the opposite side of the cell that tend to have this inclusion-like appearance. These areas of rhabdoid change tend to be associated with areas of necrosis, as you can appreciate in these pictures. And the other change that you can see in clear cell RCC, as well as in other tumor types, is the presence of sarcomatoid components, which can be just a spindle cell component NOS, as you can see here. Again, typically associated with areas of necrosis. This also qualifies the tumor as grade 4. But you may occasionally find some areas with heterologous differentiation, for example, to chondrosarcoma or other sarcoma types. Immunohistochemistry for these tumors can be useful when needed. So the typical immunoprofile of clear cell RCC is, of course, PAX8 positive. Keratin 7 will be negative in most cases, but can be focally positive and can be positive particularly in areas, for example, around cysts. When these tumors have cystic areas, keratin can be positive in those cystic structures. CA9 is typically diffusely positive, and this is because this is one of the genes that is activated by the HIF pathway. And the expression of CA9 tends to be circumferential in the membrane of the cells. That means that the entire cell membrane stains in what has been called a box-like pattern, and that's important to distinguish it from clear cell papillary renal cell tumor, as we will see later on. CD10 is also positive in clear cell RCC, although this is not a very specific marker. And again, keep in mind that when you have a tumor that has transitioned to high-grade, BAP1 may be sometimes useful because some of these high-grade areas, especially if they have intracytoplasmic hyaline globules, can show loss of BAP1 expression. Not a diagnostic marker, but that's more of a prognostic marker in this tumor type. Another marker that I didn't put in this picture but can be helpful is GATA3. GATA3 is a marker of tumors that arise in the distal nephron, and therefore it will be negative in clear cell RCC, which arises in the proximal nephron, and that's important to distinguish it again from clear cell papillary renal cell tumor. So in the differential diagnosis, we have this tumor type that is not as uncommon as one would think. We encounter it quite commonly in clinical practice, actually, and it shows an association with end-stage renal disease. This is clear cell papillary renal cell tumor. And this tumor type tends to be solid and cystic, as I'm showing here, or predominantly cystic. And in the past, we used to call this tumor clear cell tubulopapillary renal cell carcinoma because it tends to have both papillary and tubular components, as you can see in this picture. But we dropped the term tubulo, and now we just call it clear cell papillary renal cell tumor. But keep in mind the tubular architecture, which is somewhat characteristic of this tumor type. Non-specific, but somewhat characteristic. This tumor also shows clear cell cytomorphology, low-grade nuclear features. The tubules have been described to adjust to each other, sort of like the pieces of a puzzle. So that's, I think, a useful feature, as you can see here. And at higher magnification, you can appreciate not only the low-grade nuclear features of this tumor, but also another finding that's quite characteristic, which we called reverse polarity, because the nuclei of the tumor cells tend to be located towards the apex rather than towards the base. Immunohistochemistry can also be helpful to distinguish it from clear cell RCC because these tumors are going to be diffusely positive for keratin 7, and they will be diffusely positive for CA9, but the pattern of CA9 expression in this tumor is basolateral, meaning that it's not the entire circumference of the cell membrane that is going to be highlighted by the stain, but only the basolateral membrane. And the site to look for the basolateral staining pattern is in the tubules, right? Don't look in areas that look more solid or that are composed of compressed tubules, because it's going to be hard to assess that there. Just go to the tubules or go to the cystic areas, and there you will be able to see this cup-like shape of, this cup-like pattern for the stain. Another useful stain, in my opinion, is GATA3. Again, GATA3 is a marker of origin in the distal nephron. These tumors originate in the distal nephron and express GATA3, which will be negative in clear cell RCC. CD10 is typically negative in this tumor type, but again, not very specific. And the more I do it, the more I find clear cell tubular papillaries or clear cell papillary renal cell tumors that show expression of CD10. They are also negative for AMACAR, another stain that occasionally can be useful if needed. Also in differential of clear cell RCC are TFE3 fusion renal cell carcinomas. And these tumors really span a relatively wide spectrum, much wider than what we initially expected when we first described this entity. But the classic examples are tumors with papillary architectural and clear cell cytomorphology. But keep in mind that the fusion partner in these tumors determines in part the appearance of the tumor. So now we know that we have tumors that have as fusion partners for TFE3 the genes MET15 or NONO, which can resemble low-grade neoplasms such as multilocular cystic neoplasm of low malignant potential or even clear cell papillary renal cell tumor. So again, TFE3 fusion renal cell carcinoma spans the spectrum. What I'm showing you here are the more classic examples: a tumor with papillary architecture, clear cell cytomorphology, typically high-grade nuclear features. That's when you have to think about this tumor type. And the other characteristic finding is that the papillae tend to have hyalinized papillary cores. They also frequently have calcifications, and they tend to show a mixture of cells with clear cytoplasm and eosinophilic cytoplasm. So all those things, especially in a young patient, especially in a young female patient, have to make you think about TFE3 fusion renal cell carcinoma, an aggressive tumor type to keep in the differential of clear cell renal cell carcinoma. And then we have renal cell carcinomas that have mutations of a gene called elonging C. And this used to be called also TSEB in the past, TSEB mutated renal cell carcinoma. The TSEB gene was renamed ELOC, so elonging C, and that's what we call them right now. These tumors are within the spectrum of morphologic spectrum of what we consider renal cell carcinoma with fibromyomatous trauma, meaning that these are tumors that are going to have clear cell cytomorphology. The cells typically have voluminous cytoplasm, but the most characteristic finding is that the stroma tends to be abundant and fibromuscular. So within this group of tumors that have renal cell carcinoma with fibromyomatous stroma morphology, we will have two big groups. One of tumors that are driven by alterations of the ELOC gene, and the other one, the other group is composed of tumors that have alterations of the TSC1, TSC2 genes. So here I'm showing you an example, and it's very hard to tell them apart by morphology. You have to use either molecular or now immunohistochemistry to distinguish one from the other within this group. So what I'm showing you here is a case that was confirmed to represent an ELOC RCC with molecular studies, and you can appreciate again that this tumor shows clear cell cytomorphology, significant overlap with clear cell RCC. To be honest, I mean, the main difference here is at low power, as you can see in this picture, the very prominent fibromyomatous stroma. But when you go at higher magnification, it might be difficult to tell apart this tumor from a clear cell RCC. But unlike clear cell RCC, these tumors tend to be diffusely positive for keratin 7. And Another thing that can be useful when you, within this group of tumors, want to distinguish those that are ELOC mutated from TSC1, TSC2 mutated, is to use GPNMB. So GPNMB will be positive in tumors that are driven by TSC1, TSC2 within this group of tumors with fibromyomatosis trauma, whereas those that have ELOC mutations are going to be negative for GPNMB. So that's a stain that can be occasionally useful within this group of tumors. So I'll leave this table for you to look at, but basically here I'm mentioning the main stains that I use when I want to make a differential of a tumor with clear cell cytomorphology. Again, clear cell RCC, mostly negative for keratin 7, although again, it can be positive, especially in low-grade lesions or also in areas with cystic architecture. CA9 is circumferential and diffusely positive, CD10 positive. Amacar can be positive in a subset. Vimentin is positive. I don't use Vimentin, but if you want to do it, it will be positive in this tumor type. Cathepsin K is negative, GATA3 is negative. Clear cell papillary, again, to distinguish it from clear cell RCC, we can use the pattern of CA9 staining, the diffuse expression of keratin 7, and in my opinion, the other thing that's very useful is the expression of GATA3. TFE3 RCC tends to be negative for keratin 7 and CA9, although there are cases that have been reported as positive for CA9. CD10, again, non-specific, but these tumors tend to express cathepsin K, so that's a useful marker in these cases. And if you want to use melanocytic markers, some cases may also show expression of melanocytic markers. I don't use the TFE3 antibody because it's not a great antibody. I mean, you get significant background staining in pretty much every tumor type, although if you have it, you can use it as well. And TFE3 fusion tumors tend to be diffusely positive for TFE3. The other thing that you can use, and I don't know if this will be in boards or not because it's relatively new, but there's a marker for TFE3 fusion tumors and TFEB altered tumors as well. It's not entirely specific, and it will be also altered in some tumors to TSC1, TSC2, but has proven to be useful in TFE3 fusion RCCs when you suspect it is TRIM63. So this is an ISH assay. So if you have a high suspicion for TFE3, you can do the TRIM63 initially and then go to molecular studies to confirm. As I mentioned, ELOC RCC and renal cell carcinoma with fibromyomatosis trauma, which have to be distinguished either by molecular studies or you can do that also by doing GPNMB, are both going to be positive for keratin 7 and CA9 with a box-like pattern for CD10. And keep in mind again here that GPNMB positive tumors within this group favor an RCC with fibromyomatosis trauma without an ELOC mutation, whereas ELOC RCCs are going to be mostly negative for GPNMB. So now let's go to the second most common type of renal cell carcinoma that we see in clinical practice. This is papillary renal cell carcinoma, and this tumor spans a wide spectrum, but this is a clinically wide spectrum, but overall, it shows a better prognosis than clear cell RCC. Remember that we do not subclassify these tumors any longer as type 1 and type 2 for several reasons, one being that type 2 is a very heterogeneous group that includes tumor types that can be classified now with molecular studies. And the characteristic finding within this group of papillary RCCs that you will find in all the books and you can be tested on is the presence of trisomies of chromosomes 7 and 17. Another association that it's relatively rare, but I think people like to test is the association of papillary RCC with gain of function variants in the MET oncogene. And these tumors that are associated with germline variants of the MET oncogene tend to be bilateral and multifocal. And keep in mind that papillary RCCs show a tendency to infarct spontaneously. So you can have tumors with total or subtotal infarction, and that's that's not very uncommon in papillary RCC. So the differential diagnosis of these tumor types includes papillary renal neoplasm with reverse polarity. These tumors were recognized relatively recently, and in the past were certainly classified within the spectrum of papillary renal cell carcinoma, but we now need to distinguish them from papillary RCC because they have good prognosis. FH deficient RCC is a rare but very important tumor type because it's very aggressive, and a subset are associated with germline alterations of FH, and it can be the first presentation of the hereditary leiomyomatosis and renal cell carcinoma syndrome, so you don't want to miss that tumor type. TFE3 RCC is also in the differential of papillary RCC, mostly because it has papillary architecture. Mucinous tubular and spindle cell carcinoma is a rare tumor, but also and one that should be considered, especially when you're dealing with a low-grade papillary RCC. The same for metanephricoma, a tumor that is benign. Nephroblastoma, which is exceedingly rare in adult patients. And then we have a group of TFEB amplified, not the fusion tumors, but the TFEB amplified RCCs, which are rare but very aggressive and may have papillary architecture, and they are part of the differential diagnosis of high-grade papillary renal cell carcinomas. So macroscopically, again, these tumors are mostly solid, and keep in mind that they may show areas of infarction or necrosis, and the areas of infarction can be quite large. That's, again, infarction, very common in this tumor type. A low magnification, you can appreciate that the morphology in most of these tumors is distinctly papillary, as you can see in that micrograph. Here again, another micrograph just showing that calcifications are not uncommon in these tumor types. The papillae of these tumors have terminal circulation, so they can become hypoxic. These areas can become calcified, and it's not uncommon to find abundant pseudomonas calcification in this tumor type. Most of them show eosinophilic cytomorphology, and there are two findings that I think are quite useful to support this diagnosis. Not that they are entirely specific findings, but they are useful in context. One is the presence of pigment, hemosiderin pigment, within the cytoplasm of the tumor cells. That's something that we find quite commonly in papillary renal cell carcinoma. And the other one is the presence of foamy histiocytes within the core of the papillae, which you can appreciate there in this picture. Here I'm showing you two additional pictures of papillary RCC. On the left, you can see that some areas can look tubular as well, and the papillae can be very crowded, so the papillary architecture can be sometimes difficult to identify when the tumors are very solid. Here you can here you can see another example where the papillary cores are completely dilated by the presence of these foamy histiocytes that are completely filling the papillary cores. Here you can see a vessel within the papillary core, completely surrounded by this foamy histiocyte. So this is another appearance that these tumors may have. And the other thing that's quite common in papillary RCCs, because they are prone to infarction, is the presence of cholesterol crystals that you can appreciate in these two figures. These are just higher magnification micrographs, just to show again the presence of intracytoplasmic hemosiderin pigment and calcifications. So regarding grade, again, these tumors have a wide spectrum from what we used to call type 1 papillary RCCs, which are tumors composed of cuboidal cells with low nuclear grade, to others that look like this one, which are grade 3 with columnar cells, and even tumors with nuclear pleomorphism that we would call grade 4. So whenever you have a papillary RCC with high-grade nuclear features is when you have to start thinking about things like FH deficient RCC or TFEB amplified RCC. and specifically FH deficient RCC, which is the one you don't want to miss. So remember, high-grade papillary has a wide differential diagnosis. As I've mentioned before, these tumors can have solid areas where the papillae are very crowded, and they may even have solid areas. And in fact, this tumor was entirely solid and was still a papillary RCC, and the solid variant of papillary RCC has been described. Fortunately, they have the same immunoprofile as just regular papillary RCCs. The other thing that can happen in papillary RCC is that you can have low-grade spindle cell areas that may make you think about the possibility of sarcomatoid transformation, but keep in mind that if they have spindle cell morphology and they are very bland looking without a transition to nuclear grade, you should consider the possibility of these areas representing a low-grade spindle cell component of a papillary RCC rather than true sarcomatoid transformation. Having said that, I've seen cases with low-grade sarcomatoid transformation where the low-grade sarcomatoid component ended up metastasizing. But just be aware that areas with low-grade cytomorphology or low-grade nuclear features and spindle cell components in these tumor types have been described as papillary renal cell carcinoma with low-grade spindle cell areas, which may not necessarily represent sarcomatoid transformation. And also keep in mind that papillary RCC can have clear cell cytomorphology. I wouldn't say that this is common, but it does happen. Here I'm showing you an example of a papillary RCC that had the typical immunoprofile. It had trisomy 7 and 17 and had clear cell cytomorphology. You can appreciate in the picture on the right that some of the cells had, again, accumulation of hemosiderin pigment, which I find to represent a very useful finding. There are also papillary RCCs that have biphasic appearance. In the literature, initially, these tumors were called biphasic squamoid alveolar RCC because they have these alveolar-like structures that contain in the center these squamoid-like cells with more abundant cytoplasm. We now know that these tumors are just part of the spectrum of papillary RCC. They have the same molecular alterations, including trisomy 7 and 17 and MET mutations, and therefore we now consider them to represent biphasic papillary RCC. Another finding that is quite characteristic in this tumor type, and you can find it in at least focally if you look carefully, is the presence of and peripoiesis of neutrophils, as you can see here in the picture on the right. And in the differential of low-grade papillary renal cell carcinomas, we have a tumor type that has been recently described as papillary renal neoplasm with reverse polarity. These tumors in the past were, of course, classified as type 1 papillary renal cell carcinomas, but we now know that they are molecularly different and clinically indolent. These tumors are characterized by papillary architecture, low cuboidal cells with eosinophilic cytoplasm, and the most characteristic finding that will make you think about them is that they have reverse polarity with the nuclei oriented towards the apex of the cell. So these cells are this tumors are associated with KRAS hotspot KRAS mutations. Those are codon 12 mutations, and they behave indolently. So it's important to distinguish them from papillary RCC. They will have a similar immunoprofile in that they will express like papillary RCC, keratin 7, and AMACAR diffusely, which are the markers that are typically positive in papillary RCC. But unlike papillary RCC, these tumors will be positive for GATA3 and also for L1-CAM, which is another marker of distal nephron origin. So that's what I'm showing you here. At higher magnification, again, a papillary renal neoplasm with a reverse polarity, and on the right, you can see the GATA3 staining that can be quite useful. Then this might be a little bit too much. I don't think this is going to be in boards, but we have recently recognized that there's a subset of tumors that we used to classify as papillary RCC that have NF2 alterations as probably the primary driver of the tumor. And they were initially described as biphasic hyalinizing psammomatous renal cell carcinoma. So these are, in general, high-grade tumors that have a biphasic appearance, which is different from the biphasic appearance of the biphasic papillary that I've shown before, in that in these tumors, there are nests of cells where the cells located in the center of the nests are going to be smaller than the ones located at the periphery. And that's the opposite pattern of what I've shown in biphasic papillary RCC. So these tumors can resemble TFEB fusion tumors, which are indolent, unlike these, which are aggressive, in that they tend to have this biphasic morphology with nests of cells where the smaller cells are in the center, the bigger cells are in the periphery. And as the name implies, they often have this hyalinized stroma and calcifications, which can be psammomatous. They also tend to have the accumulation of this basement membrane-like material, these globules of basement membrane materials. Again, something that we see also in TFEB fusion tumors, something to keep in mind. Of course, unlike TFEB fusion tumors, this tend to present in older patients. And again, they tend to be high stage and they are aggressive. And as I've mentioned before, NF2 inactivation is thought to be the main driver of this tumor type, and therefore these tumors will show loss of expression of Merlin, which is the protein product of the NF2 gene. And that's what I'm showing you here. Normally in renal tubules, Merlin is expressed at in the apical aspect of the membrane. And here you can see entrapped tubules with retained expression in this tumor that has complete loss of Merlin expression. So a useful stain if you have it available. Not many labs have it. And within the differential of papillary renal cell carcinoma, we also have another very important, albeit rare tumor type, which is FH deficient RCC. And these tumors tend to be very aggressive. They commonly have papillary architecture, and they can be certainly misdiagnosed as papillary RCC. So whenever you have a high-grade papillary RCC, keep in mind the possibility of an FH deficient tumor, and personally, I always try to rule it out doing immunohistochemistry. Having said that, there are some very rare examples of low-grade FH deficient RCCs, but that's beyond the point of this talk, so not necessary to talk about that right now. Unlike papillary RCC, these tumors are going to be negative for keratin 7, so that's going to be a clue. And they will show loss of expression of FH in the tumor cells and expression or overexpression of 2SC, which is an oncometabolite that is the consequence of loss of FH function. And typically you want to see diffuse expression with nuclear expression of this marker to call it positive. So again, useful things that you can have in your armamentarium when you try to distinguish it from papillary RCC. Again, a subset of these tumors are associated with germline FH alterations, and therefore some of these patients will need genetic assessment. And the other thing I want to mention about FH deficient RCC is that if you ever have a patient that presents with metastasis and the patient had a prior history of a nephrectomy with tubulocystic renal cell carcinoma, that is most likely an FH deficient RCC that was misdiagnosed, because they tend to have this morphology closely resemble that of tubulocystic RCC. So this is one of those cases that I've seen in my practice. This patient had a prior diagnosis of tubulocystic RCC in the kidney. He underwent a nephrectomy, and then he presented with this metastasis in the retroperitoneum. And when you go at high magnification, you can appreciate that the tumor cells are eosinophilic, have large large nuclei with very prominent nucleoli that are cherry red, and they have a perinucleolar halo. So I haven't mentioned this until now, but these are the typical morphologic features of FH deficient RCC. Eosinophilic cells, nuclei that are grade 3, typically, and nucleoli that are very prominent, large, eosinophilic, and surrounded by a perinuclear halo. And again, that's the book description of it. Of course, there's a spectrum morphologically, but I think if you're tested, you're probably going to be attested on tumor that looks like that. So very typical. In the differential diagnosis of low-grade papillary renal cell carcinomas, we have also an indolent tumor that we call mucinous tubular and spindle cell carcinoma. And it's, I would say relatively indolent, right? Because it shows better behavior than the high-grade papillary RCCs that I've been showing. This tumor tends, again, tends to present in women. And as the name implies, it has mucinous components, and it has spindle cell components, and it has a mucinous appearance in the stroma. And this is not, this is not true mucin. It's not mucus. It's glycosaminoglycans, right? Here you can see the spindle cell areas of one of these tumors. And again, these tumors are typically low grade, and immunohistochemistry is not very helpful here because they are also going to be positive for AMACAR and keratin 7. It's been reported that they are typically negative for CD10, whereas papillary RCC is positive for CD10. So that's something that you could potentially use, but I don't know how useful that is. In my experience, I don't use that stain too much. So the main thing is morphology in the clinical context. It's been published that there's an ISH marker that is called V, like Victor, STM2. But as far as I understand, I think most labs don't have that marker. But that is a marker that is relatively specific of this tumor type. Metanephric adenoma is a benign tumor also that tends to present in middle-aged women, and is part of the differential of low-grade papillary RCCs, what we used to call type 1 papillary RCCs in the past. These tumors are going to be positive for WT1 and CD57. So those two stains are useful to distinguish it from papillary RCC, but most importantly, a very significant proportion of these tumors, if I don't remember incorrectly, is something close to 90%, show hotspot BRAF V600E mutations. And therefore, if you have the mutation-specific antibody, that can be quite useful too, because these tumors are going to be positive for BRAF V600E. Again, these tumors are low grade with small cells that are cuboidal to round with high NC ratio, and therefore, when you look at them at low magnification, they tend to look quite blue. And they show tubular to tubulopapillary architecture, and that's why they are part of the differential of low-grade papillary RCCs. And I'll skip Wilms tumors because you'll probably see this with peds, and they are extremely rare in adult patients. So here's a table again summarizing the immunohistochemistry. They can be useful to distinguish these different tumor types. You can look at it on your own later, but I think the main thing that I want to point out here is that mucinous tubular spindle cell carcinoma, papillary renal neoplasm with reverse polarity, and papillary RCCs are all positive for keratin 7 and AMACAR. So this differential can be sometimes difficult. Keep in mind CD57 and WT1, as well as BRAF V600E for metanephric adenoma. Metanephric adenoma tends to be, typically focally or multifocally positive for keratin 7 or negative, and AMACAR is negative. So sometimes, these two stains can be useful to distinguish it from papillary as well, or at least to think about it. And I think that's pretty much it for this. Keep in mind FH for FH deficient RCC, and in some cases 2SC can be helpful, especially if you have a missense mutation of FH. You can have retained antigenicity and some FH expression, and therefore in that context, expression of 2SC can be helpful, especially if you have a nuclear pattern of expression. So now let's go to the third tumor type that we find more commonly in clinical practice, and this is a benign tumor. We find one of these every week. I'm sure you all do. This is renal oncocytoma. This is a clinically benign tumor that can be, in my opinion, easily diagnosed with morphology and a couple of stains. It can grow during active surveillance, and sometimes this is due to intratumoral bleeding, and this makes the clinicians worried, and they will take it out and they will ask you, are you sure it's an oncocytoma because it grew like 2 or 3 centimeters within, a few months? And there you have to assess whether there's intratumoral bleeding or not. That's usually the cause of a rapid enlargement of these tumors. There are vanishingly rare reports of metastatic oncocytomas. If you believe in them, I believe that many of these tumors are now within the spectrum of TSC1, TSC2 altered tumors, and they were called oncocytomas in the past. But anyway, be aware that there are reports of metastasizing oncocytomas in the past, most of them without molecular assessment. And the other thing to keep in mind is that the distinction between oncocytoma and a new entity that we call low-grade oncocytic tumor, in my opinion, for the most part, requires immunohistochemistry because they have significant morphological overlap. So differential diagnosis of oncocytomas includes benign tumors as well as renal cell carcinoma types that tend to be low-grade. So we have within the benign tumors, we have low-grade oncocytic tumor and eosinophilic vacuolated tumor. And within the renal cell carcinoma that overlap with oncocytoma, we have Chromophobe RCC, and in particular, the eosinophilic variant of Chromophobe RCC, SDH deficient RCC, and eosinophilic solid and cystic RCC. Here I'm showing you growths with the classic appearance of oncocytomas. These tumors tend to have this mahogany brown color, and they may have a central scar, typically well circumscribed, unencapsulated, as you can appreciate in this growth picture. And at low magnification, these tumors are going to be solid with a nested architecture, although you can have variations, including some tumors with tubular architecture, which is not totally infrequent. You can have tumors with cords and trabeculae, but this is the typical appearance of an oncocytoma, with this, solid nests of tumor cells within a stroma that is very edematous or myxoid. Here you can see the features of this tumor at higher magnification. The cells show abundant cytoplasm that is oncocytic, granular, and brightly eosinophilic. Nuclei are round and regular, and they have a nucleolus that is typically easy to see at 20x. Here you can see one of the nests of cells in this tumor. Again, appreciate the granular characteristics of the cytoplasm, very brightly pink. And the myxoid or edematous stroma is also quite characteristic, at least focal. But as I mentioned before, you can have variation. You can have tumors with microcysts and with tubules, the areas of the stroma where it looks more fibrous. So again, keep in mind all these variations, which do not mean that, this tumor is not an oncocytoma. I think that there are 2 stains that are essential when you have to distinguish oncocytoma from the tumors that I mentioned previously, and these are c-KIT as CD117. And now you can also add GPNMB if you have it available in your lab. So oncocytomas are going to be diffusely positive for c-KIT and for CD117. And the third stain that I think it's essential to distinguish oncocytoma from the other tumor types that I think I said this wrong. The 2 stains that are essential to distinguish oncocytoma from the other tumor types that I mentioned before are CKIT, or also called CD117, and keratin. Those are the two stains that are essential. You can add a third one that's GPNMB. Sorry, I'm getting tired. So remember, CKIT CD117 is diffusely positive in oncocytoma, and keratin 7 is typically negative in oncocytoma, or described as negative, although in my experience, these oncocytomas are not entirely negative for keratin 7. You may still see scattered cells that are positive, or even you can even see some focal positivity, and that's not incompatible with the diagnosis of oncocytoma. But ideally, when you're tested on these tumors, the immunoprofile that they will give you is that they are keratin 7 negative and CKIT/CD117 diffusely positive. GATA3 can be occasionally useful. And in this case, this tumor type is going to be negative for GATA3, whereas what we call low-grade oncocytic tumors are positive for GATA3. And GPNMB in this tumor type is going to be negative, unlike tumors that have overlapping morphology and are driven by TSC1, TSC2 alterations, which are typically positive for GPNMB. So remember, when you have an oncocytoma, I would say mandatory, if you want to distinguish it from LOT, for example, are CD117, keratin 7. If you have in the differential other tumors, with alterations of TSC1, TSC2, and you're not entirely sure of your results with those two stains, you can add GPNMB. And I think that's usually enough to make the distinction between these tumor types, for the most part, or at least in 90% of the cases. So here I'm showing you a typical oncocytoma. Keratin 7, as you can see here, it's negative in the tumor, it's positive in entrapped tubules, but as I've mentioned before, it's not always that negative. You can see 1 or 2 cells staining in the tumor sparsely throughout the tumor, and CKIT is diffusely positive, as you can see on the right. Keep in mind that oncocytomas can have unusual features that can suggest that they can be worrisome if you're not aware that this can happen, but they are not associated with bad prognosis. These tumors are still indolent, and these findings are the presence of extension beyond the kidney, in particular to perirenal or sinus fat, and the presence of vascular invasion. Those two, are always worrisome, but not associated with an aggressive clinical behavior in this tumor type. The third finding that can be worrisome sometimes is the presence of nuclear atypia, although this tends to be degenerative and quite easy to distinguish from true pleomorphism. The things that, in my opinion, are incompatible with the diagnosis of oncocytoma are the presence of brisk mitotic activity, let's say, I don't know, more than 5 to 10 mitosis per 10 high power fields. If I have a tumor with mitotic activity like that, I would really hesitate to make a diagnosis of oncocytoma, even if the tumor looks quite classical, and the presence of tumor type necrosis. These two findings are, in my opinion, not compatible with the diagnosis of oncocytoma. Here you can see what I mentioned before, an oncocytoma, which is otherwise typical, with tubular architecture extending into the perirenal fat. This happens, again, you can mention it if you want in your report, but don't think that because of this finding, it's going to be malignant. And here you can see another oncocytoma extending into a vessel in the renal sinus. And again, this finding is not associated with malignant clinical behavior. This is the type of nuclear atypia that we find in oncocytoma, and it's the degenerated type 2 nuclear atypia that we also call endocrine atypia, because it has this dark but homogeneous chromatin with nuclear enlargement, but you don't typically see very pleomorphic or very large nucleoli. And again, like this sort of like homogeneous characteristic of the chromatin is quite consistent in this degenerative type atypia. You can see that it can get pretty scary. The nuclei can get pretty big, but the architecture and the stroma is otherwise typical of an oncocytoma, and so is the immunoprofile of these tumors. You can see that this tumor is diffusely positive for KIT, and it's mostly negative for keratin 7 with some scattered cells positive only. So Again, this is just a degenerative nuclear atypia and is not incompatible with the diagnosis of oncocytoma. So there are some practical things that are a point of discussion among GU pathologists. One is whether we can render a diagnosis of oncocytoma in biopsies of renal masses, because it's well known that some tumors with eosinophilic or even oncocytic cytomorphology can be heterogeneous, and it can have areas that look like oncocytoma and some other areas that are consistent with renal cell carcinoma. So in my opinion, you can. The way I do it is by saying low-grade oncocytic renal neoplasm consistent with oncocytoma in this limited sample or in this biopsy. And it's a discussion you need to have with your clinicians and let them know, listen, there are sampling issues in the sample I have. What I'm seeing is oncocytoma. That doesn't mean that there cannot be another component. So if you have any clinical suspicions for something more worrisome, then you should manage the patient accordingly. And the other thing that I find quite difficult to do based on morphology alone is to distinguish oncocytomas from what we now call low-grade oncocytic tumors. So currently, I'm doing at least c-KIT/CD117 and keratin-7 in all my oncocytic tumors that look like oncocytoma. And that's mostly because I want to pick up the ones that are currently classified as low-grade oncocytic tumors. I don't think it's a critical distinction because in the literature so far, low-grade oncocytic tumors seem to behave indolently, but they are a distinct tumor type, and therefore I think it's somewhat relevant, at least academically, to make that distinction. And the other problem is that some of the characteristics that have been described in low-grade oncocytic tumors, such as the presence, for example, of perinucleolar halos that are what we call partial halos, and that they are not, large enough to push the entire contents of the cytoplasm close to the membrane, as it happens to be the case in Chromophobe RCCs, are, it's a finding that was originally described in low-grade oncocytic tumors, but I've seen it also in oncocytoma. So there's significant overlap between these tumor types, again, arguing that immunohistochemistry is needed. In fact, if I show you these two pictures and I tell you which one is the oncocytoma and which one is the LOT, I bet that everyone will say the one on the left is the low-grade oncocytic tumor, but when we did the stains on this case, the low-grade oncocytic tumor happened to be the tumor on the right, and the oncocytoma happened to be the tumor on the left. So again, for this distinction, in my opinion, you need immunohistochemistry. So here I'm showing you low-grade and low-grade oncocytic tumor, part of the differential of oncocytoma. Well-circumscribed tumors, also without a capsule. The cells are eosinophilic, oncocytic, and then they tend to have also these areas of edematous stroma, but instead of containing well-defined nests within this area, they tend to have this sort of like cords of tumor cells. And this appearance has been called boats in a bay. So this is the bay. This is the bay here. And these are your boats. So this is a quite characteristic finding of this tumor type, albeit not necessarily specific, because I've seen areas that look like this in oncocytomas as well. Morphologically, they are oncocytic. Like oncocytoma, they show low nuclear grade, and they show this partial nuclear halos. Again, all findings that are non-specific, as I've shown you before, because oncocytomas may also look like this. So here I'm showing you, for example, a tumor that was diagnosed as an LOT, and it's the tumor that I've shown at low magnification before. And these tumors typically show the opposite staining pattern that you see in oncocytomas, meaning that they are diffusely positive for keratin-7, and they are entirely negative for c-KIT/CD117. The other differential diagnosis of oncocytomas is Chromophobe RCC. And I will expand a little bit on Chromophobe RCC because it's another tumor type that you may encounter in your board exams. This is a type of renal cell carcinoma with relatively good prognosis when you compare it to clear cell RCC, but about 8% of them will show sarcomatoid transformation and aggressive clinical course. And you can certainly have tumors with aggressive clinical course, even if they don't have sarcomatoid transformation. Keep in mind that the WHO ISUP grading based on nucleoli that we used for clear cell RCC and papillary RCC does not apply to this tumor type. It doesn't apply to TFEB tumors either, and to other tumor types. So we mostly use it for clear cell RCCs and papillary RCCs. And molecularly, these tumors are characterized by a recurrent set of monosomies that affect chromosomes 1, 2, 6, 10, 13, 17, and 21. And they show a relatively high frequency of p53 alterations, about 25% overall, but this is much higher in sarcomatoid tumors, in some series close to 100%. Eosinophilic tumors are the ones that are the main differential diagnosis of oncocytoma and low-grade oncocytic tumors, and those are the ones that can fool you. So the typical chromophobe RCC is going to look like this, right? It's going to have this nuclei that show very dark chromatin, irregular nuclear borders, which in this case it's more visible there. And the contents of the cytoplasm are displaced towards the membrane, and therefore they have this sort of like plant cell-like appearance because of the prominent cell membranes that you can see in this picture. Again, about 8% of them will show transformation to sarcomatoid RCC or sarcomatous transformation. And what's quite interesting is that in chromophobe RCCs, the transition to sarcomatoid areas tends to be very abrupt, as you can see here. You have your typical component and then your sudden transformation to sarcomatoid components of the tumor. But of course, as I mentioned before, the ones that are more problematic when you have to distinguish them from oncocytomas are the eosinophilic chromophobe RCCs, such as the one that I'm showing here. And in this case, what I think it's very useful, because this is a feature that you see very consistently in chromophobe RCC, is the presence of this long linear vessels that can show variable degrees of perivascular hyalinization. So you can see this long linear vessels, especially if they show perivascular hyalinization, have to make you think about the possibility of chromophobe RCC. Again, same tumor at higher magnification. You can see that here you don't have the typical appearance of the chromophobe RCC. Here the cytoplasm is eosinophilic, but if you look closely, you will see that the cell membranes are somewhat prominent. And again, the vasculature is quite typical. Compare this to the clear cell RCCs that I've shown before, where the vasculature is branching, sort of like with a chicken wire appearance, whereas here the vessels are long and linear. This tumor type, chromophobe RCC, can also be easily distinguished from oncocytoma based on its immunoprofile, because these tumors are going to be positive for both markers. They are going to be diffusely positive for keratin 7 and also diffusely positive for KIT/CD117, right? Whereas oncocytomas, as we've mentioned before, are negative or only focally positive for keratin and diffusely positive for KIT. So immuno is quite useful. Another tumor type that is part of the differential of oncocytoma is what we call eosinophilic solid and cystic RCC. These tumors, as the name implies, are eosinophilic, solid, and cystic. They tend to present in women more frequently, and they have this eosinophilic cells with abundant eosinophilic cytoplasm. And at higher magnification, you can appreciate that some of these cells will have this intracytoplasmic basophilic granules that we call basophilic stippling. That is a quite characteristic finding and has to make you think about these tumor types. These tumors are also TSC1, TSC2 driven, so they are going to be positive, for example, for GPNMB. They tend to be positive for cathepsin K. Here at higher magnification, you can appreciate the basophilic granules. And the immunoprofile of these tumors is also quite helpful, because these tumors express a marker that is otherwise quite rare in renal cell carcinomas, which is keratin 20. So keratin 20 in this tumor type is going to be positive, although it's not typically diffusely positive, but more commonly either focally or multifocally positive. This is another tumor type that is part of the differential of oncocytoma, and you don't want to miss, because in this case, most of these tumors are associated with a germline alteration, and these are SDH-deficient renal cell carcinomas. Like oncocytomas, these tumors are eosinophilic, solid, unencapsulated, and they show a very low nuclear grade. Here you can appreciate in this higher magnification micrographs that the nuclei are round, regular, so they have significant morphologic overlap with oncocytoma, although they typically don't have this edematous stroma that we see in oncocytomas. And at least focally, the cells have this sort of like flocculent or bubbly cytoplasm. At higher magnification, again, you can appreciate the presence of intracytoplasmic vacuoles and the floccular appearance of the cytoplasm, but otherwise they show significant morphologic overlap with oncocytoma. They are going to be mostly negative for keratin and KIT. And here, of course, the most useful stain to do is SDHB. So regardless of the SDH alteration that these tumors have, they will lose the expression of the B subunit of the complex, and therefore SDHB can be used for screening these tumors. And then of course you have to do molecular analysis, and in some patients go directly to assessment of the germline. Now here you can see that this tumor that I was showing is completely negative for expression of SDHB in comparison to the normal renal parenchyma adjacent to it. Keep in mind that some missense variants can show retained expression of SDHB within the tumor, but this expression will be typically of lower grade and less granular than what you will see in the adjacent benign renal parenchyma. And I'll go quickly over this one. Eosinophilic vacuolated tumor, an indolent tumor that in the past we used to call hot, high-grade oncocytic tumor. And that gives you a clue about the nuclei of these tumor cells, which are high grade, that is grade 3. These tumors tend to have this edematous, again, or myxostroma, very prominent vessels with very juicy muscular walls. And at higher magnification, you can appreciate the tumor cells that are typically eosinophilic and vacuolated, but not subtle. You know, the vacuolations are not subtle. The vacuolations are very, very prominent, as you can appreciate in these pictures. They can have tubular architecture, but again, you can see the size of this intracytoplasmic vacuoles, which is quite striking and easy to recognize. The vessels, again, are also super helpful because they are very prominent vascular wall, and the nuclei, at least focally, tend to be grade 3. That's why we call them high grade in the past. These tumors are TSC1, TSC2 driven, and therefore they will express GPNMB. So here is the table that you can review on your own later. But again, what I want to point out, the two main stains, keratin 7 and KIT, diffusely positive and negative or only focally positive in oncocytoma. The opposite pattern is seen in LOT, diffuse expression of both in Chromophobe RCC. And the rest expression is more variable, but keep in mind that the two tumor types that are driven by TSC1, TSC2 alterations are going to be positive for GPNMB, so this can be useful. And SDH deficient RCC is typically negative for keratin 7 and KIT, but unlike the other tumor types, will show loss of expression of the B subunit of the SDH complex, and that will help you to differentiate them from the other tumor types. I think I'm done with renal tumors. I don't know if there are any questions so that I can take a little break before we go into renal tumors.
Thank you, Dr. Acosta. So there are a few questions here. I think there is one question from Dheeraj inside Zoom. So Dheeraj, do you want to unmute yourself and ask it to Dr. Acosta, please?
Yeah.
Go ahead,
Hello?
please.
Oh,
Yes, yes.
yeah.
Dr. Acosta, usually the conventional chromophobe RCC is known for its favorable prognosis. And does the sarcomatoid dedifferentiation transform it into a aggressive tumor? And how is grading applied to sarcomatoid component in the subtypes? Because we usually don't use WHO ISUP grading for these cancers.
Yeah, DJ, thank you for the question. I think that's a great question. Both are. So yeah, sarcomatoid transformation in chromophobe RCC is typically associated with an aggressive clinical behavior. These tumors tend to metastasize. Also, molecularly, what happens in these tumors is fascinating when they become sarcomatoid. There are a couple of studies about this, but I mentioned the monosomies that these tumors have, which are 1, 2, 6, 10, 13, 17, and 21, right? So when you look at these sarcomatoid tumors and you do a copy number analysis, you will see that they go back to a baseline diploid. So they become diploid again. So they go back to a diploid baseline, which means that these monosomies sort of like disappear. But when you look at those chromosomes, they have global loss of heterozygosity. So what appears to happen is that these monosomic chromosomes duplicate and take the tumor back to a diploid or near-diploid baseline, and they also acquire TP53 mutation. So they become molecularly very complex and clinically aggressive for sure. And these are the tumor that within the group of chromophobes, this tend to be enriched among metastatic tumors. As for grading of chromophobe RCCs, there's no widely accepted system for grading them. There have been some systems proposed. I think one of them was proposed several years ago by Glado Paner, but currently we just don't grade them. And when they have sarcomatoid transformation, we mentioned that it has sarcomatoid transformation. Having said that, there are things that I mentioned within this tumor type. For example, if there's extensive necrosis and things like that that point to a more aggressive behavior, I do mention that. But we don't. There's no widely accepted grading system. In other tumor types that are graded, when they are sarcomatoid, they turn into grade 4 by definition. But in this tumor type, I just mentioned that they have sarcomatoid transformation.
Thank you, Dr. Acosta.
Yeah.
Thank you, Dr. Acosta. There is another question from one of our colleagues on YouTube who is watching from Colombia. So the question is, do you have any cases with clear cell RCC and papillary clear cell tumor concomitant?
Yeah, for sure. There are cases that have this hybrid morphology where you have a component that looks like clear and stains like a clear cell papillary renal cell tumor now, and another component that looks like clear cell renal cell carcinoma. And those cases are quite puzzling, although not entirely surprising because, for example, VHL mutations have been described in tumors that have the phenotype of clear cell papillary renal cell tumor. And more recently, there have been 2 cases that I'm aware of, at least reported, of tumors that had the appearance and immunophenotype of clear cell papillary renal cell tumors, and they ended up metastasizing. So I think there is some overlap, and I've certainly seen cases, and they are well described, of tumors with clear cell cytomorphology that have areas that look like a clear cell papillary renal cell tumor and an area that looks like clear cell renal cell carcinoma. So the way I have dealt with those cases in the past, I go by the worst diagnosis. So I call them clear cell renal cell carcinoma. And I put a note saying that there are foci that show morphologic features similar to clear cell papillary renal cell tumor. However, in the diagnostic line, I would call those cases clear cell renal cell carcinoma. Or at least personally, that's, I go by the worst finding.
Right, thank you, Dr. Acosta. One last question, or it is more of a comment. So another colleague of ours from Italy, so who has this comment that they have encountered 2 cases of metastatic oncocytoma, and one of the case they have reported, and both the cases had only liver metastasis, and he wanted to share that maybe those are not biological metastasis, but mechanistic metastasis because of connection to the vein or something like that. But as you mentioned that those cases are exceedingly rare. So do you have any comment on those?
So that's a great comment again, and I'm thankful for that comment because I truly believe that. I think, like leiomyomas, maybe these tumors can metastasize, but that doesn't mean that they are going to pursue a very aggressive clinical course. And when you resect the metastasis, maybe these patients do all right. DJ and I recently looked at a case of a metastasis in the liver of a tumor that looked like an oncocytoma, but had a very specific molecular finding that has not been described before. So yeah, I'm happy to discuss that offline as well, if they want to. But I think some of these tumors, and this tumor looked characteristically like an oncocytoma. So I think that there is a chance that there are tumors that are phenotypically oncocytomas with the same immunophenotype and metastasize. And they are not necessarily clinically malignant in that if you resect the metastasis, these patients do all right. I agree with their comment.
Thank you. I think I will see that if we can connect Luca with you.
That would be great.
You
Yeah.
can discuss it offline. Another last question from a colleague of ours is that, which is not exactly related, that the 6th edition of WHO, will it be available in 2027 where the renal tumors will be updated?
It should be. Yeah. I mean, the WHO is a meeting this year. So yes, next year we should have an updated classification.
Right. I think those are all questions that I found online related to the renal tumors. Yeah, if you would like to take a little break, so please go ahead, Dr. Acosta.
No, it's fine. I think we can probably, if everyone's okay with it, if I just faint, you can DJ can come pick me up, but I can continue and just go briefly over germ cell tumors. I think that germ cell tumors are, in my opinion, a fascinating topic, but maybe not as sport relevant as renal tumors. So we can go over it more like faster if that's okay.
Sure, please. Thank you so much.
Yeah, no problem. All right, so for those out there who are still awake, let's talk about germ cell tumors now. And germ cell tumors in the testis are divided into two big groups. What we call postpubertal germ cell tumors and prepubertal germ cell tumors. There are different classifications. You can also find what we call the developmental classification of these tumors. I don't want to get too granular into this because that's more for the subspecialist, but what I want you to know is that there are groups. There's a group of tumors that is largely prepubertal, and those are germ cell tumors that are not associated with GCNIS, and they have a morphology that is consistent with teratoma, with yolk sac tumor, or mixed tumors with teratoma and yolk sac tumor components. Whereas the tumors that we see in the postpubertal patients are largely associated with GCNIS, with some exceptions. And unlike prepubertal tumors, which are mostly indolent, so prepubertal teratomas, invariably indolent, yolk sac tumors, a subset, have malignant potential. About 15% of them will behave aggressively. 15 to 30% of prepubertal yolk sac tumors will behave aggressively, whereas postpubertal germ cell tumors associated with GCNIS, even if they look like entirely mature teratomas, are by definition malignant. So within the GCNIS associated tumors, we have two big groups, seminomas and non-seminomas, and within the latter, we have embryonal carcinoma, yolk sac tumor, postpubertal type teratoma, and choriocarcinoma. And within the group of tumors not associated with germ cell neoplasia situ in postpubertal patients, we have mostly one tumor type, which is spermatocytic tumor. So we will discuss today tumors of postpubertal patients, and we will go over those that are associated with germ cell neoplasia situ, and we will also briefly touch on spermatocytic tumor. And I think what you need to know about these tumors is not a lot, but enough to recognize them, and at least when you're talking about GCNIS related tumors, be able to subclassify them into seminoma, and non-seminoma, and within non-seminoma, recognize some important things that are associated with prognosis, just for example, like the presence of a component of choriocarcinoma or the presence of a predominant component of embryonal carcinoma. Okay, so let's start with GCNIS-derived germ cell tumors. I will skip the epidemiology and pathogenesis. We'll go straight to risk factors. So the risk factors that are well described out there for this tumor types is cryptorchidism. This increases the risk to 3 to 5 times the risk of the general population. But what's really important here is that the time of orchiopexy is very important, because this risk is about twice the risk of the general population if this defect is corrected early, whereas late orchiopexy, especially after puberty, is associated with a much higher risk. And this risk is not only for the testis that was cryptorchid, but also for the contralateral testis. And remember that once you have GCNIS, the chances of developing cancer are very high. So within 2 years, testis that have GCNIS will develop invasive germ cell tumor. So typically GCNIS has to be treated, and we won't go into the options because it might be too much for today, but keep that in mind. Prior germ cell tumor in a contralateral testis increases the risk of the germ cell tumor in the remaining testis. The risk is increased between 3 and 10 times that of the general population. And keep in mind that about 5% of seminomas are bilateral. And this risk manifests mostly within the first 5 years of initial diagnosis. A family history is also a very well-known risk factor. And for some reason, having a brother with a germ cell tumor leads to a higher risk of developing germ cell tumor than if you have a son or a father with germ cell tumor. The highest risk of germ cell tumors is in patients with gonadal dysgenesis and the presence of a Y chromosome. So these patients may not necessarily have male phenotype, and they can have dysgenetic gonads or even ovotestis, and patients with androgen insensitivity syndrome, which are due to inactivating mutations in the androgen receptor gene. So these two groups of patients are the ones that are at higher risk of developing germ cell tumors. You see from 15 times to 50 times the risk of the general population. But keep in mind, within this group, the presence of a Y chromosome is crucial. But I don't want to go into too much detail. It might be too much for what you need for boards. So as I mentioned before, post-pubertal patients, 95% or more of the tumors that you're going to see are going to be associated with the common precursor, germ cell neoplasia situ. Germ cell neoplasia situ, as the name implies, is an in situ lesion within seminiferous tubules, and that's what I'm showing you in the picture here. And it's composed of these atypical neoplastic germ cells that are present in the spermatogonial niche, meaning at the base of the tubule, they have large angulate nuclei, so squared off nuclei like what you see in seminoma, and clear cytoplasm as you see in seminoma as well. They tend to form a continuous band of neoplastic cells below the Sertoli cells, displacing the Sertoli cells towards the center of the tubules, and therefore they have this appearance of a string of pearls, as you can see on the right. Also in this picture, when you compare it to normal seminiferous tubules, you can see that tubules that are affected by germ cell neoplasia situ tend to lose maturing spermatogenesis. And you may also have other findings in association with this precursor, such as microcalcifications and different degrees of peritubular hyalinization, which is not very striking in this case. GCNIS is not visible on gross examination, of course. This is an in situ microscopic lesion, and the immunoprofile of this lesion is identical to that of seminoma, meaning that it will express pluripotency factors such as OCT4, NANOG. It will also express some markers of seminoma like podoplanin or D240, CD117, SOC17, and it will be negative for SOX2 and C30, which are markers of embryonal carcinoma. But if I have to use, think in most cases you can identify GCNIS based on morphology, but if you need to use immunohistochemistry, the stains that I recommend doing are OCT4 ideally, or if you don't have it, do D240. Why? Because CD117 or CKIT has been reported to be positive rarely in spermatogonia of peripubertal patients, and that is, just normal non-neoplastic spermatogonia. So CD117 is not entirely specific, whereas OCT4 expression and polyplanin expression is not seen in normal spermatogonia, and that's why I prefer this two stains. Sorry. These tumors, like seminoma, undergo events of whole genome duplication, and therefore they have a triploid or near tetraploid DNA content. But unlike seminoma and other invasive phenotypes of germ cell tumor, GCNIS mostly lacks an isochromosome 12p, which is the hallmark finding of invasive GCNIS-derived germ cell tumors. And what we call intratubular seminoma is believed to be part of a continuum with GCNIS, meaning a progression from GCNIS. But here the cells are no longer restricted to the spermatogonial niche, but instead they will move away from the spermatogonial niche and fill the entire tubule, going towards the lumen. So the most important general concept that you need to have about GCNIS-derived germ cell tumors is that there are two big groups: pure seminoma and non-seminomatous germ cell tumors. Each represent about half of all the cases. And this distinction is important because they are managed differently, right? For example, if you have a patient with clinical stage 1, with a clinical stage 1 testicular tumor, the kind of chemotherapy that will be given as adjuvant treatment, if that's needed, is going to be different for seminoma and non-seminoma. So, this distinction is quite important. Within a non-seminomatous germ cell tumor, as you can see in this graph, the majority are going to be mixed tumors that may have a component of seminoma, but of course have at least one component of non-seminoma as well. Whereas only 30% are going to be only 30% are going to be pure non-seminomatous germ cell tumors, such as pure embryonal carcinoma or pure teratoma. And I want to give you a couple of important concepts about staging of testicular tumors, because staging is important in every tumor type, but in this tumor is particularly important, especially when you're considering the possibility of giving adjuvant treatment. So T1 tumors are tumors that are confined to the testis parenchyma and do not have lymphovascular invasion. T2 tumors are tumors that extend beyond the testis parenchyma, meaning that they go into the epididymis, or they go into the hilar fat, or they go through the vaginalis, the visceral vaginalis, or tumors that are confined to the testis and have lymphovascular invasion. So even if the tumor is confined to the testis and there's vascular invasion, that makes it a T2, right? So T2, a tumor that goes beyond the testis or that has lymphovascular invasion. T3 are tumors that show extension into the spermatic cord that is continuous with the primary tumor. Whereas if you have discontinuous invasion of the cord, and that is the stroma of the cord, not tumor present within vessels in the cord, but tumor invading the stroma of the cord, and the tumor is discontinuous with the primary tumor, it's been proposed that those should be staged as M1. This is a recommendation I entirely disagree with, and we will have a paper coming out in the American Journal of Surgical Pathology shortly showing that this practice is probably inadequate. But for now, the recommendation by the AJCC is that this discontinuous involvement be considered M1. So let's go over first seminoma. Again, remember, within this group of GCNIS-derived germ cell tumors, seminoma 50%, non-seminoma 50%. Seminomas grossly are solid. They tend to be well circumscribed, although they can have sort of like this diffuse edges, as you can see here. They may have areas of petechiae, but large areas of necrosis are not common. And their cut surface has been described as sort of like fish skin, like lymphomas, when you cut through them. The cells are very similar to those of GCNIS in that they are intermediate size with angulate nuclei that have been called squared-off nuclei in the literature. Here you can see entrapping an area of the reedy testis with hyperplasia of the reedy testis, which is a mimicker of Yolk sac tumor. At higher magnification, you can appreciate also another characteristic finding in this tumor type, which is the infiltration by lymphocytes. They can have a lymphocytic or lymphoplasmacytic infiltrate that can be variably prominent. They tend to have fibrous bands that go within the tumor. In some cases, may have prominent granulomatous inflammation, and in some cases, the granulomatous inflammation may obscure the tumor. Here again, appreciate the angulate nuclei and nucleoli that are typically quite, prominent. You can see them at 10 to 20x quite easily. There are variations, of course, of this tumor type. Sometimes you will have seminoma cells filled with glycogen resembling signet ring cells, as you can see in these two pictures. Sometimes you will have this cohesion of the cells that will give the tumor this pseudo-papillary appearance. But as you can appreciate in this immunostain on the right, this tumor was diffusely positive for OCT4, as you would expect in seminoma. And in older patients, keep in mind the possibility of lymphoma as a differential diagnosis, which is also a tumor that tends to be monomorphic and can, grow. It tends to grow mostly in between seminiferous tubules. The seminiferous tubules show some degree of reactive changes, but of course, in these cases, you will not see germ cell neoplasia site 2. So the markers, I will point this out. If you're comfortable with germ cell tumors, you typically won't use immunohistochemical markers in 90% of your cases to distinguish between seminoma and different types of non-seminoma. But if you need them, the scenario where you more commonly need it is when you have to distinguish seminoma from embryonal carcinoma, because seminomas, of course, span a spectrum. And within that spectrum, we have what we used to call in the past anaplastic seminoma that can have some morphological overlap with embryonal carcinoma with more atypical nuclei. So if you need to do immunohistochemistry for that distinction, I will leave this table for you to explore. But if you need to do immunohistochemistry for that distinction, what I use are D240 and SOC17 as markers of seminoma, which are negative in embryonal carcinoma, and CD30 and SOX2 as markers of embryonal carcinoma, which are negative in seminoma. So these two are the main markers. CD117 is also useful if you want to use it, but I find these markers to be superior. When you need to distinguish seminoma from spermatocytic tumors, keep in mind that KIT is typically positive in spermatocytic tumors in about 70% of them. So that can be a pitfall, but you can use other things such as OCT4, which is positive in seminoma and is negative in spermatocytic tumor. And also a more recent stain, the stain against the carboxy terminus of the SSX protein, which is typically diffusely positive in spermatocytic tumors and either negative or focally positive in seminoma. And the other thing I want to mention about immunohistochemistry is that keratins are considered largely negative in seminomas. However, if you go to the older literature, you will see that a significant proportion of seminomas actually do express keratin, albeit most commonly either focally or multifocally rather than diffusely, but I've seen seminomas with diffuse keratin expression. So keratin expression is not incompatible with the diagnosis of seminoma. Another thing I want to point out about immunohistochemistry is whenever you're thinking about the possibility of a metastatic tumor to the testis or involvement of the testis by a tumor from other side, some tumors can have SAL4 expression. SAL4, which is a general marker of germ cell tumors, can be expressed also by other tumor types. Carcinomas, for example, some carcinomas of GI origin, and in particular, INI1 deficient tumors tend to express SAL4, and some of them may even express OCT4 as well. So these markers are not entirely specific. And regarding keratin expression in seminomas, that's what I want to show you here. This tumor was otherwise a typical seminoma, some fibrous bands going into the tumor. This typical cytomorphology here the cytoplasm was not entirely clear. It was more eosinophilic in areas, but you had the lymphocytic infiltrate that you see in seminomas, and this tumor was sent to us because it was diffusely positive for keratins, including keratin 7 and keratin 5. But as you can see on the left, it was also diffusely positive for OCT4, and it had the typical appearance of seminoma. So again, keratin expression not incompatible with the diagnosis of seminoma. Within the group of non-seminomas, we will start by reviewing embryonal carcinoma. This is a tumor that is very common in mixed germ cell tumors, is seen in most of them, 87% of them. And this is because seminoma, in order to give rise, so everything comes from GCNIS. GCNIS is thought to give rise to seminoma, which then can differentiate to the histologic types of non-seminomas. But in order to do so, it is thought that seminoma has to first differentiate to embryonal carcinoma, and from embryonal carcinoma to Yolk sac tumor, teratoma, etc. And therefore, the presence of embryonal carcinoma is seen in most non-seminomatous germ cell tumor. I hope that makes sense. But is, in contrast, quite rare as a pure tumor. As you can see here, only 2.3 to 10% of these tumors are pure. So morphologically, grossly, they tend to be very heterogeneous when you cut through them, and that is because these tumors have large areas of hemorrhage and necrosis, and that's what you're seeing here. These tumors, the one on the right is big, the one on the left is small, with this very heterogeneous, variegated cut surface, and that's because these tumors have lots of necrosis, lots of hemorrhage. Another example here after fixation, again, just to show the heterogeneous cut surface. And morphologically, these tumors are composed of polygonal or epithelioid cells with abundant cytoplasm that is typically amphiphilic to basophilic, but can be eosinophilic as well. And a big difference with seminoma is that the nuclei look much more atypical with large nucleoli, and something that is almost invariably found in this tumor types is the presence of tumor necrosis, as you can see here. They tend to be very mitotically active, lots of mitosis per 10 high power fields, not that you need to count them, but keep in mind they span a spectrum. They have a wide spectrum of architecture, and also a wide spectrum of cytomorphology. So here you can see tumor with sort of like trabecular arrangement on the left and on the right. They can have pseudoglandular arrangement, papillary arrangement. In this case, you can see an embryonal carcinoma mimicking Yolk sac tumor because you have these structures that appear to be Schiller-Duval bodies with a central vessel. And this tumor also has a more clear cytomorphology, but when you do the stains, it's positive for OCT4. OCT4 is going to be positive in seminomas and in embryonal carcinoma, not in the rest of the GCNIS-derived germ cell tumor types. And therefore, OCT4 expression is incompatible with Yolk sac tumor. And it's also positive for SOX2. SOX2 is a marker of embryonal carcinoma. It's also positive in what we call ENT now, but that's beyond the point of this talk. So this is just a morphologic variant of embryonal carcinoma. And keep in mind that both seminoma and embryonal carcinoma, as well as other tumor types, but those are the two where we see this more commonly, can have scattered syncytial trophoblastic cells, as you can see in this picture. That doesn't make this mixed tumor with a component of choriocarcinoma. To have choriocarcinoma, you need not only the syncytial trophoblast, but also a component of mononucleate cytotrophoblast. So the presence of syncytial trophoblasts in embryonal carcinoma or in seminoma is quite common and can be associated with moderately elevated levels of serum HCG. HCG is a marker of choriocarcinoma as well, as we will see later. And of course, you can have intratubular components of embryonal carcinomas. In this case, you can see it in association with GCNIS here, and you also see it here on the right, maybe with some differentiation to Yolk sac tumor. We've discussed the markers before when we were talking about their distinction from seminoma. Remember, SAL4 positive in all of these tumors, OCT4 will be positive in seminoma and embryonal carcinoma, so it's not useful for that distinction. So the ones that I use are D240 and SOX17, positive in seminoma, negative in embryonal, C30 and SOX2, positive in embryonal, negative in seminoma. The other distinction that may need to be made is sometimes between an embryonal carcinoma with scattered syncytial trophoblasts and choriocarcinoma. So in those cases, you can use OCT4, which will be positive in embryonal carcinoma, negative in trophoblastic tumors, and also GATA3, which is going to be positive in trophoblastic tumors, negative in embryonal carcinoma. To distinguish them from yolk sac tumor, I think OCT4 is usually enough. Again, OCT4 should be negative in yolk sac tumor, but if you want, you can use FOXA2 and glypican-3, which are markers of yolk sac tumor and tend to be negative in embryonal carcinoma. So now let's go over yolk sac tumor. And remember, when you talk about GCNIS-associated yolk sac tumor, you have to specify that it's post-pubertal type yolk sac tumor, because these tumors are completely different from a biological and clinical perspective from prepubertal type yolk sac tumors that occur in children and are not associated with GCNIS. Like embryonal carcinoma, it's mostly present in mixed germ cell tumors, very infrequent as a pure tumors in post-pubertal patients. And if you have yolk sac tumor in a primary tumor, it's been suggested that those tumors have a lower risk of retroperitoneal recurrence in clinical stage 1 patients. However, if you have this tumor in metastasis, that's typically not a good thing, especially if the tumor was not entirely resected, because this phenotype tends to be resistant to chemotherapy. And yolk sac tumor is considered a more differentiated phenotype of germ cell tumor than seminoma and embryonal carcinoma, and it has, differentiation towards elements that resemble the endoderm or the hypoblast of the embryo, as well as some elements that resemble this black-neck mesenchyme, including some areas with vasculogenesis. Pure yolk sac tumors, primary yolk sac tumors, that is, tend also to have a variegated cut surface, may have areas of necrosis, but importantly, they can have, and this is quite commonly found in this pure yolk sac tumors, areas of cyst or areas with cystic appearance, as you can appreciate here, and as you can appreciate here. So you will find cysts within the tumor. And this is perhaps the germ cell tumor type that has the widest morphologic range, but the typical yolk sac tumor appearance that you will be shown in exams, at least, is what we call the microcystic appearance, which is characterized by this, sort of like microcystic arrangements of cuboidal to stellate cells with much less nuclear atypia than what you have in embryonal carcinoma. And typically what they will show you also is the presence of tumor cells with this intracytoplasmic eosinophilic globules. This is, of course, not a specific finding. For example, you can see this in trophoblastic tumors as well, but it's typically describing yolk sac tumor. Remember, yolk sac tumors can have a wide range of appearances, from glandular tumors to tumors that have this sort of like microcystic architecture. Here I'm showing you an example with tumors that have signet ring cell-like appearance that is also seen in a subset of these tumors. On the left, you can see a glandular component of yolk sac tumor. Remember that especially pre-chemotherapy yolk sac tumors can have this endometrium day 17 appearance, in that they have clear vacuoles within the cytoplasm that can be located below the nucleus, as you can see in the picture on the left. On the right, you can see what we call polyvesicular vitelline morphology in yolk sac tumor. And this one can be quite tricky because the cells tend to be low cuboidal to flat, and tumors that are predominantly polyvesicular vitelline can look very, very bland. And that's what I'm showing you, for example, in this picture. So the key here, in order to not misinterpret this as a benign tumor or as a benign cystic lesion, is to sample these tumors generously. And if you do so, you will typically find a transition to more typical areas of yolk sac tumor, or of other types of non-seminomatous germ cell tumor, as you can see here on the right in the transition to embryonal. Like all germ cell tumors, they are going to be positive for SALL4. Remember, negative for ROC4, important to distinguish them from seminoma and embryonal carcinoma if you need to. And the markers of Yolk sac tumors that I use are FOXA2, Glypican-3, and HNF1 beta. These are all not super specific, but FOXA2 in particular is quite specific and a very good marker, a nuclear marker. It's the master regulator of the Yolk sac phenotype. So it's a stain that if you have it, I recommend using it. AFP is useful, and in context can be quite specific, but I don't like it. This stains that target proteins that are secreted tend to have a very high background. So the same with HCG. It's not my favorite marker. What I do take into consideration, though, is the presence of elevated serum AFP, because like choriocarcinoma, this tumor type is associated with a specific, well, not specific, but with a serum marker, with a marker that we can detect in serum and can be in context useful to support your diagnosis. So serum AFP, of course, is a supported finding if you're thinking that a tumor has YSD appearance. Keratins are typically positive in this tumor type and diffusely positive. As I mentioned before, keratins can be positive in seminoma. They tend to be focally or multifocally positive in embryonal carcinoma, but in Yolk sac tumor tend to be diffusely positive. And GATA3 and CDX2 are potential pitfalls because they are expressed, each one in about 70% of Yolk sac tumors. And therefore, if you have, for example, a glandular Yolk sac tumor and a carcinoma or adenocarcinoma is in your differential and you see that the tumor expresses CDX2, that can be a potential pitfall. So keep that in mind. Losing my voice. Trophoblastic tumors now, we'll discuss specifically choriocarcinoma. This is an uncommon component of mixed germ cell tumors and very uncommon as a pure tumor, perhaps the most uncommon pure non-seminomatous germ cell tumor. This patient, I haven't mentioned this before, but most germ cell tumors have a very predictable pattern of spread. They go to the retroperitoneal lymph nodes first and to specific retroperitoneal lymph nodes, depending on whether they arise on the right or the left testis. But an exception to that are choriocarcinomas, because choriocarcinomas tend to invade the blood vessels really early in the course of the disease, and therefore they tend to skip sometimes the retroperitoneal lymph nodes and go directly, especially to two sites, which are the lungs and the brain. And I think if they give you a patient with choriocarcinoma in an exam, they will typically tell you that it's a patient that presents with lung metastasis or with brain metastasis, or even with what we call choriocarcinoma syndrome, which are episodes of massive bleeding where the patient dies before even getting to get chemotherapy for these tumors because they have a massive bleeding, for example, in the brain. So these tumors are exquisitively sensitive to chemotherapy, but because, again, they metastasize early, they can have widespread metastasis, and the metastasis can bleed, are associated with a higher mortality than other subtypes of germ cell tumors. Grossly, they are also quite, they have a quite characteristic appearance because they resemble the appearance of a placenta grossly, right? They have this sort of like spongy, dark red appearance, as you can appreciate in this picture. Also in this picture, this was a T4 tumor with extension into the scrotum. And again, on the right, a higher magnification or zoomed in, you can see the presence of this spongy appearance that could be hard to distinguish from a section of a placenta if you look at it too closely. Another example, just showing that these tumors, because they are very vascular or very bloody, tend to have these areas of gross hemorrhage. And microscopically, these are biphasic tumors for the most part. There's a monophasic variant, but the vast majority of the tumors and the ones you're going to be tested on are biphasic tumors that by definition have not only syncytial trophoblast, but they also have to have a component of mononucleate cytotrophoblast in order to be called choriocarcinoma. Because, again, remember, Scattered syncytial trophoblast can be present in other germ cell tumor types. That doesn't make it a component of choriocarcinoma. So these tumors recapitulate the development of the placental villi. So they tend to have these large blood lakes, and the syncytial trophoblasts tend to be associated with the blood. In a higher magnification here, I'm showing you the biphasic nature of the tumor with multinucleate syncytial trophoblast and mononucleate cytotrophoblast. They tend to be very mitotically active. There's significant nuclear atypia. The syncytial trophoblasts tend to be associated with the areas with the blood lakes. They can have intracytoplasmic hyaline globules. They can have fibrin in between the cells, large areas of bleeding. They often have areas of necrosis as well. And again, they sort of like recapitulate the development of the placental villi. So I think, in my opinion, when you look at these pictures, the most important or the most difficult differential diagnosis is going to be with an embryonal carcinoma with scattered syncytial trophoblast. So again, what you can use is OCT4, which is going to be negative in trophoblastic tumors, and GATA3, which is going to be positive in trophoblastic tumors, whereas embryonal carcinomas are going to be positive for OCT, negative for GATA. Here I'm showing you in this picture the presence of intracytoplasmic hyaline globules in the mononucleate cytotrophoblast there, and the large syncytial trophoblastic cells. To compare with the picture that I've shown you before, this is not choriocarcinoma. This was a mixed germ cell tumor with scattered syncytial trophoblasts, but not a component of choriocarcinoma. The markers, just keep in mind that SAL4 will be positive mostly in the mononucleate cytotrophoblast, but can be negative in the syncytial trophoblast. OCT4 will be negative. Inhibin and HPL, I find it quite useful, and they are going to be positive mostly in the syncytial trophoblast. The same with ACG, beta ACG is mostly positive in the syncytial trophoblast. However, this is another stain that I don't like to use, mostly because the protein is secreted, and therefore you tend to have a very high background staining. So like in yolk sac tumors, knowledge of the serum markers is sometimes more useful than doing a beta ACG stain. And when we talk about serum levels compatible with a diagnosis of choriocarcinoma, we're typically talking about levels that are above 5,000, but more typically above 10,000, and you can even have levels as high as, 500,000 or 1 million. Like beta ACG, when you have true choriocarcinoma, tends to be very, very high. GATA3 is the best marker, I think, for trophoblastic tumors. It marks both components, the syncytial and the mononucleate cytotrophoblast. And again, useful when you have to distinguish it from embryonal carcinoma, but not from yolk sac tumor, because yolk sac tumor 70% of the times is going to be positive for GATA3. And P63 can be used as well because it's positive in the cytotrophoblast and it's negative in the other germ cell tumor types. I'll go over post-pubertal type teratoma quickly because we're running short on time. This tumor also has to be specified as post-pubertal type because, as I mentioned before, there are prepubertal type teratomas which have important differences with this tumor. The prepubertal type teratomas are not associated with GCNIS and are clinically benign and occur in children. These tumors are malignant by definition, associated with GCNIS, and occur in postpubertal patients. And they are malignant regardless of their appearance. Even if they appear to be completely mature, they are malignant. So that's why when you have a teratoma, the same when you have yolk sac tumor, you have to specify whether it's prepubertal type or postpubertal type. GCNIS associated teratoma and yolk sac tumors are always going to be postpubertal type. This is the most common pure non-seminomatous germ cell tumor, and grossly, they can have a very variable appearance, but they tend to be solid or solid and cystic, and they can have areas with a sort of like myxoid or cartilaginous appearance. Here you can see another example, but they tend to be somewhat heterogeneous when you cut through them. But perhaps what I want to convey here from the gross examination, I think this is particularly useful for distinguishing prepubertal type teratomas from postpubertal type teratomas, is that postpubertal type teratomas typically don't have well-formed structures, including hairs and teeth. Those are things that you can find in prepubertal type teratomas, but are not found in postpubertal type teratoma. So occasionally, prepubertal type teratomas can be diagnosed in postpubertal patients. I don't want to get into that now. But here you can see a testicular tumor where you can appreciate the presence of hairs there. So again, when you have this and you see only a teratoma, that's most likely a prepubertal type teratoma, not a postpubertal type teratoma. Remember, postpubertal type teratomas, hair, teeth, not a common finding, or I would say, shouldn't be found in a postpubertal type teratoma. Regarding morphology, these tumors can show differentiation to pretty much any tissue type that you find in the body, so there's no point in going over all of them. What I will mention, though, are some things that are useful to distinguish this postpubertal type teratomas from prepubertal type teratomas. Because postpubertal type teratomas are tumors with a complex genome and molecular alterations, they are going to have nuclear atypia. They will have not uncommonly hypercellular areas. And that's different from what we see in prepubertal type teratomas, which tend to be, cytologically bland. And the other important distinction is that prepubertal type teratomas tend to have what we call an organoid appearance. And what we are talking about when we talk about an organoid appearance is an appearance that closely recapitulates the mature tissue that they resemble, right? So for example, if you have an area with respiratory differentiation, you will have the epithelium, the mucosa, and maybe a wall of smooth muscle, even cartilage around it. Whereas postpubertal type teratomas are much more disorganized, and therefore they don't have this organoid appearance. You can have large areas of cartilage and dilated glands that may measure more than 5 centimeters, but do not qualify as somatic type malignancy arising in teratoma. But that I will skip that because that might be too much for the purposes of this talk. IHC is not useful for teratoma. SAL4, remember, it's going to be mostly negative in the very mature components. It can be positive in the glands of teratomas, but it's not uncommon to see mostly absent staining for SAL4. So I think the main problem is when you have a postpubertal patient with a pure teratoma and you don't find GCNIS. And that's the particular scenario where assessment of isochromosome 12p, which is a hallmark finding of postpubertal type postpubertal type germ cell tumors, but not a prepubertal type germ cell tumors, can be useful, right? So that particular scenario, pure teratoma without concurrent GCNIS. But I think that might be a little bit too much for this talk. Just keep in mind, if they ask you what's isochromosome 12p useful for, is one, to distinguish a tumor of germ cell origin from a somatic tumor, right? A tumor of true somatic origin. And within germ cell tumors, it's also useful to distinguish a prepubertal type teratoma or yolk sac tumor from a postpubertal type teratoma yolk sac tumor. Sensitivity is not 100%, is between 80 and 90% overall, but specificity is very good. And finally, spermatocytic tumor. This is a very rare tumor that occurs in postpubertal patients and is a tumor that is, unlike the prior ones, not associated with GCNIS, and therefore not associated with an isochromosome 12p. Very rare, as you can see, 1 to 2% of all the tumors, but because it's rare, is something that is probably going to show up in some tests, most likely. They tend to occur in older patients than in seminoma, but more recent series have shown that about a third of the patients have up to 40 years of age. And unlike germ cell tumors that we've been discussing in the prior section, which can occur in the gonads or in extragonadal locations, this can occur only in the testis. And 90 to 95% of them, I would say probably closer to 95% of them, are benign. But there are some rare tumors that show aggressive clinical course, and this is typically associated with sarcomatoid transformation. So for practical purposes, the message here, and that's what we do here in Indy, when you have one of these spermatocytic tumors, if you can, try to embed the entire lesion because you don't want to miss an area of sarcomatoid transformation. Grossly, these tumors tend to be multilobulated, as you can appreciate in these pictures. You have multiple nodules or multiple lobules, They can have this myxostroma. Here again, you can see another example. You can appreciate the lobulation of the tumor, although here the mass appears to be more round. But if you look within the parenchyma, you will see that there are lobules within the parenchyma. So that's quite characteristic in the gross examination. And microscopically, they are solid tumors, although they tend to have areas that are pseudocystic, and they are not. These are quite frequent, actually. And at high magnification, they show what we call a tripartite appearance with the presence of small lymphocyte-like cells, intermediate cells, and large giant tumor cells. So these cells sort of recapitulate the maturation of spermatocytes, right? And you can see here on the right that some of the intermediate and large cells can have this filamentous chromatin that has been called spireme chromatin, because spireme, I think in Greek, means spider. And as you can appreciate here, this filamentous appearance makes it resemble, I guess, a spider. Common findings in these tumors: mitosis. They are typically full of mitosis, and even atypical tripolar, tetrapolar mitosis. That doesn't make them malignant, right? So keep that in mind. And also apoptotic bodies. Apoptosis tend to be scattered all over these tumors. They can have reactive spermatogonia and even intratubular components of the tumor, but of course, GCNIS is not going to be present in this tumor type, and therefore, if you do OCT4, this atypical spermatogonia or reactive spermatogonia are going to be negative, and the intratubular components of the tumor are going to be negative as well. And this might be too much for this presentation, but keep in mind that there's a subset of tumors that were called anaplastic spermatocytic tumor in the past that show a monomorphic appearance. And these tumors are composed almost entirely of a population of intermediate-sized cells, and can be quite difficult to distinguish sometimes from seminoma, especially because they are going to be cell-positive, cell-4 positive like seminoma, and most of them are going to be positive for c-KIT/CD117 as well. Again, look for sarcomatoid transformation. The ones that are aggressive typically show sarcomatoid transformation, and sarcomatoid transformation in these tumors is sometimes associated with the acquisition of p53 mutations. In some of these tumors, when they show sarcomatoid transformation, they can have heterologous sarcomatous elements such as rhabdomyosarcoma or chondrosarcoma, for example. Of the markers, again, I want to highlight the SAL4 and CD117 are typically positive in this tumor type, and this is a pitfall, especially if you have a monomorphic or what we used to call anaplastic spermatocytic tumor, and you need to distinguish it from seminoma. But these tumors are consistently negative for pluripotency markers such as OCT4 and nano. So this can be useful when you need to distinguish them from seminomas. As mentioned before, the antibody against the carboxy terminus of the SSX protein is also useful to distinguish it from seminoma, because it's diffusely positive for it, whereas seminoma is either focally positive or negative. And the utility of p53 in these tumors is mostly to try to find a mutant pattern that is overexpression in areas with sarcomatous transformation. And that's pretty much all I have. I apologize for this very long talk. Please feel free to reach out and ask any questions. Happy to respond.
Thank you so much. Thanks a lot, Dr. Acosta, for this such a comprehensive overview of renal as well as, testicular tumors. So these are definitely very helpful for the residents and of course for others as well who are preparing for boards. So there are a couple of questions I will quickly read to you so that, you already have spent so much of time. So one question is that, what do you think about terminology? A 21-year-old who have a teratoma. So is it prepubertal or postpubertal?
Yeah, so that's a great question. I think, the thing to keep in mind here is that occasionally, and we've encountered that, prepubertal type teratomas can be diagnosed in postpubertal patients. And that's a very important distinction, because prepubertal type teratomas are benign. Postpubertal type teratomas are by definition malignant. So that's a very, very important distinction. So the distinction between a prepubertal type teratoma and a postpubertal type teratoma, I would say, can be done based on morphology most of the times, because they have a different appearance. As I mentioned before, prepubertal type teratomas tend to have an organoid configuration and no atypia, whereas postpubertal type teratomas are going to be more disorganized and they will have atypia. And using isochromosome 12p when needed. That is if you don't find GCNIS, of course. So any teratoma in a postpubertal patient associated with GCNIS is by definition postpubertal type teratoma. But let's say you don't have GCNIS, you have a pure teratoma. The things you can use are the presence of, organoid configuration, present that would favor a prepubertal type, the presence of atypia that would favor a postpubertal type, and the presence of isochromosome 12p that would be confirmatory of a postpubertal type. So I don't know if that answers the question. So in short, the question is, you can definitely use the terminology. There are prepubertal type tumors diagnosed occasionally in adult patients, postpubertal type patients, but that's very, very rare. Something to keep in mind, something that may have to be excluded, but not something that is commonly encountered. Does that answer the question?
Yeah, sure. Thank you. There's another question from Dheeraj. So Dheeraj, do you want to ask the question yourself, please?
Yeah. Dr. Acosta, we know that teratomas can undergo somatic malignant transformation into adenocarcinomas, embryonal neuroectodermal tumors, or rhabdomyosarcomas. Given your experience and expertise with testicular tumors, have you ever encountered a teratoma giving rise to testicular germ cell tumor or a sex cord stromal tumor?
A teratoma giving rise to a sex cord stromal tumor. That I have not encountered. What's the other question?
Yeah, teratoma giving rise to testicular germ cell tumors or sex cord stromal tumors. Because these teratomas are known for totipotency, could they differentiate into these lineages?
So I've never seen differentiation towards sex or stromal tumors. It's common to see teratomas with other components of germ cell tumors, right? As part of mixed germ cell tumor, let's say with embryonal carcinoma, with Yolk tumor. And what we currently think is that actually teratoma is the final common pathway of maturation of this different non-seminoma germ cell tumor types that either spontaneously or more commonly after chemotherapy mature to teratoma. So in the context of having a germ cell tumor that has teratoma components and other germ cell tumor components, I wouldn't assume that those other germ cell tumor components derive from teratoma, but the other way around, that the teratoma is the result of maturation of the other germ cell tumor types. As for the sex cord stromal tumor, it could in theory happen. I guess it could, but I have never seen that happen. So I have no experience.
Oh, thank you.
Yeah, thank you.
One last question, Dr. Acosta, that from one of our colleagues is that, do you diagnose diffuse embryoma pattern?
No, so that's a great question. I don't use those terms, polyembryoma, diffuse embryoma. So those are patterns of a mixed germ cell tumor that has embryonal carcinoma and Yolk tumor. So, when they form this embryoid bodies, the tumor looks diffusely like that. They used to be called polyembryoma in the past, but when you have sort of like this lacy pattern with embryonal carcinoma associated with Yolk tumor, but not forming embryoid bodies, and this was found diffusely throughout the tumor, those were called diffuse embryoma. There's no evidence that that particular pattern is associated with any specific clinical outcomes, or there's no specific clinical association. So I just call them mixed germ cell tumor with component of embryonal carcinoma and Yolk tumor. I don't use that terminology.
With that, we have come to the conclusion of today's lecture, and thank you again, Dr. Acosta, for taking your time and sharing your experience and so extensively covering these renal as well as testicular tumors. And you would be happy to hear that we really had a lot of viewers who joined from different parts of the world. We had colleagues who joined from India, Colombia, Pakistan, Poland, Peru, Italy, just to name a few. And we had actually over 200 live viewers who joined the session. And thanks to our viewers for joining. You can always follow Padcast on social media platforms and stay updated with all the upcoming lectures. And actually, because many residents are preparing for boards, so we are having a few board review sessions. So our next session is also related to board preparations. Dr. Laura Tafe will be discussing high-yield molecular pathology. This would be part one, where she will cover molecular pathology related to solid tumors. And we will also have another session later in which we will have a session on molecular pathology related to hematopoietic tumors. And I would also like to thank all the residents and fellows at Indiana University for joining today. And thank you again. Thank you, Dr. Acosta. We really
Yeah,
appreciate
no, and thank you very much for the invitation. And I might have said something crazy because I've been speaking for 2 hours straight. So if I said something crazy and it's wrong, please let me know via email. I'm happy to clarify it via email.
Thank you. Thank you so much. You didn't say anything. Thank you.
Thank you.
Thank you. Bye.
Bye.